All right, good afternoon, everybody. Today we are welcoming another guest from not quite across the pond, but across the planet. So we're welcoming Dr. Chris Anthony here to talk to us a little about the use of cardiac magnetic resonance imaging in cardiac allograft surveillance post-transplant. So just a little bit about Dr. Anthony. He completed his basic physician and cardiology training at St. Vincent's Hospital in Sydney, Australia, and subsequently completed a PhD in cardiac MRI-based tissue characterization techniques and the assessment of cardiac allograft at the Victor Chang Cardiac Institute through UNSW, which I'm not sure what that would stand for, Chris, UNSW?
It's the University of New South Wales.
Okay, wonderful, thank you. And then from there, he has had his work supported by scholarships from the National Heart Foundation and Australian Government Research Training Program. His work was awarded the President's Prize and Early Career Research Award of the Transplant Society of Australia and New Zealand in 2019, and was selected as a finalist for the Ralph Reeder Clinical Prize of Cardiac Society in Australia and New Zealand in 2020. His first-in-the-world study demonstrated that a cardiac MRI-based virtual biopsy technique for the surveillance of heart transplant rejection was safe and effective in the first year post-transplant, and it was published in Circulation. Upon the conclusion of his doctoral thesis, he completed a 2-year advanced multimodality cardiac imaging fellowship in structural echocardiography, cardiac CT, and cardiac MRI at the Cleveland Clinic in Ohio, where he was selected as the inaugural Ellen H&F Gene Braun Fellow. Outside of work, he enjoys playing soccer. I'm sure Australia's was knocked out by Argentina, right? Same day we got
absolutely.
Same day we got knocked out by Netherlands. So we're both kind of on the sad side of things here.
Thanks for rubbing that in again, but we share your pain. So.
Yes. He also enjoys indoor cycling and sampling fine Japanese whiskeys. So this is Thursday morning over there for Dr. Anthony. So we're really happy that he took the time to join us today. So Chris, please go ahead and take it away.
Thank you so much, Michael, for the very kind introduction. And thank you, everyone, for the opportunity to present our ideas and our work to you. And I'm looking forward to the discussion and feedback at the end of this brief presentation. I have no disclosures to report. So cardiac transplantation is a therapy of choice for eligible patients with end-stage heart failure. Approximately 100 Australians receive heart transplants each year, with an annual global transplant rate of roughly 5,500, which is likely to increase in the years ahead with the incorporation of the DCD, or donation after circulatory death donors, to the donor pool. Transplant recipients have a median survival of about 12 years, and that increases to about 14 years if they get through the first year post-transplant. This early attrition in the first year can be attributed to cardiac allograft rejection and infection. Therefore, balancing immunosuppression with the risk of infection, as you're aware, is especially critical in this period. To aid clinicians in achieving this equipoise, endomyocardial biopsies are performed at least 10 times a year on average in the first year post-transplant. Biopsies are fluoroscopically guided, and myocardial tissue is obtained from the interventricular septum of the right ventricle. These tissue samples are then analyzed by histopathologists for the presence of inflammatory cell infiltrate, edema, myocyte damage, and are then assigned a rejection severity grade in accordance with the International Society of Heart, Lung, and Transplantation criteria. Due to its invasive nature, endomyocardial biopsies are uncomfortable, time-consuming, result in repeat radiation exposure, and carry the risk of serious periprocedural complications, as you can appreciate from that image I showed you previously of the bioptome advancing perilously close to the right ventricular apex and having to traverse through the tricuspid valve and the subvalvular apparatus to get to that interventricular septum. Unsurprisingly, then, tricuspid regurgitation is the most common valvular complication after transplant. Although many cases are mild and clinically unimportant, there's published data that describes up to a third of recipients developing moderate to severe tricuspid regurgitation, which may then result in an additional need for reparative cardiac surgery post-transplant. Furthermore, biopsy is susceptible to operator-related sampling error and histological error. To this point in our published inter-observer analysis, we saw a Cohen's kappa of 0.47 as highlighted in that red box for the detection of significant 2-hour greater rejection between 2 experienced histopathologists from Sydney and Melbourne in 2 of the most experienced transplant centers in Australia. Cardiac MRI is therefore a valuable non-invasive tool for the assessment of allograft function, as clinicians are able to harness the benefits of CMR techniques for the evaluation of graft function and the detection of transplant rejection. The CMR techniques are depicted in the panels on this slide, where in panel A1 and A2, we have your tried and trusted SSFP long axis and short axis LV slices for the calculation of LV function and LV mass. In panel B1, we have strain-encoded sync sequences of the midventricular short axis slice, where regional changes in strain as depicted by the yellow vectors in that B2 tile on the right can be used to actually calculate regional LV or graft functional changes and measured prospectively and longitudinally. Finally, in the bottom C panel, we have MOLY-based native T1 mapping sequences showing a region of interest drawn there in the interventricular septum, with its respective T1 decay curve and relaxation times depicted in the C2 column that allow us to assess tissue characterization of the actual graft in and of itself. The added benefit of the use of serial CMR whilst combining the aforementioned techniques is it provides clinicians with the ability to track individualized sequence and patient-specific data quantitatively and longitudinally, as I mentioned, through the first year post-transplant, as was the case in the RADTAG study. This provides clinical and prognostic information of graft function with a degree of precision that is simply not currently available, as existing transplant surveillance protocols are largely based on clinical and echocardiographic parameters of graft function. As these line graphs illustrate, we were able to track functional CMR data for each individual recipient based on the type of immunosuppression regimen used and demonstrate that elevated T1 levels of values on CMR MOLY sequences were associated with increased LV mass and reduced circumferential strain over a 52-week period in the first year post-transplant, and compared that directly to a novel immunosuppression regimen that showed improved function with reduced scar formation of the graft. Moving forward, CMR-based tissue characterization sequences have provided good diagnostic and prognostic data in both transplant and non-transplant settings. For over a decade, Australian and international researchers have demonstrated that CMR-based tissue characterization techniques provide excellent sensitivity, inter-observer agreement, and good specificity for the detection of clinically significant cardiac allograft rejection. Importantly, these sequences no longer require the administration of contrast agents and exploit native tissue relaxation properties for the detection of rejection. This is especially pertinent in transplant population, as you can imagine, as these patients often have a degree of renal impairment to begin with, or develop it soon enough due to the prolonged CNI exposure. In the early days, Marie et al. Reported that increased T2 relaxation times correlated with moderate 2R or greater rejection, with good sensitivity and acceptable specificity at field strengths of 0.5 Tesla. Andrew Taylor and his group subsequently demonstrated that an elevated early relative myocardial contrast enhancement ratio was highly diagnostic for the presence of acute rejection, and subsequently postulated that expansion of the extracellular matrix with subsequent accumulation of gadolinium also occurred in acute allograft rejection. This was thought to be secondary to myocyte edema and necrosis caused by the inflammatory cell infiltrate related to immune-mediated rejection. When he combined that early contrast enhancement sequencing with the T2 stir sequence, he achieved a near perfect diagnostic accuracy for rejection in his dataset. Subsequently, this work laid the foundation for expansion of these ideas into T1 mapping type sequences or T2 mapping sequences, which are parametric sequences that utilize extracellular tissue expansion and edema to quantitatively measure acute inflammation and edema. The most recent of these meta-analyses published in JACC Imaging last year by the Cedars-Sinai group evaluated 10 of the most historically impactful papers in the CMR rejection space. In their hierarchical modeling-based summary ROC curve pool sensitivity and specificity analyses, a T2 mapping-based assessment, as depicted by the red bar charts over there, demonstrated the highest diagnostic accuracy, followed by T1 mapping in blue and ECP mapping in black. The binary assessment of LG techniques depicted as the purple bar graph for the detection of acute rejection across the studies that was analyzed was not as good as mapping-based techniques, but importantly, the caveat with this entire data set and meta-analyses is that there's significant heterogeneity in study designs, imaging protocols, diagnostic thresholds, and CMR-based definitions of rejection across the included studies, a point that we'll address in the limitations of our study as well. Moving forward, the next logical question to ask is, as with all scientific research, does any of this research-based work actually translate to clinical practice? And this is a question we sought to answer. Of the 2 phases of the NIDAC study that we conducted, 401 CMR studies and 354 biopsy procedures were performed in 106 participants. In the validation phase, we demonstrated excellent sensitivity and incremental specificity when T1 and T2 mapping techniques were combined. A key strength of the CMR technique was its excellent negative predictive value. From this data, we determined optimal threshold values for the diagnosis of clinically significant grade 2R rejection. In the randomized phase of the study, we randomized 40 heart transplant recipients to either a CMR-only arm or a biopsy-only arm for rejection screening and management in the first year post-transplant. Our patients were screened and randomized at 4 weeks post-transplantation to a non-gadolinium contrast 25-minute rejection-focused abbreviated CMR study or standard biopsy procedure with ISHLT grading groups. Rejection detection studies were performed at standard intervals and if clinically indicated. They occurred on average 11 times per patient in the 52 weeks post-transplant. Incorporated into the safety design of our study was the capacity for the treating physician to request a biopsy in either arm for clinical concern at any point throughout the follow-up period. Intention to treat analysis was employed for all study endpoints, which included acute rejection, immunosuppression exposure, infection, hospitalization, and death. Our inclusion criteria was stable consenting adult cardiac transplant recipients at week 4 post-transplantation. 17 patients were excluded from an original 57 patients who were screened for eligibility for meeting one of the exclusion criteria of either hemodynamic instability, severe uncontrolled rejection, ongoing sepsis, renal failure recurring hemodialysis, contraindication to CMR, or any issues related to retained device leach, which was a safety issue with regards to CMR scanning, especially repetitive serial CMR scanning. Our study was adequately powered to demonstrate that CMR was non-inferior to 2 independent senior Australian histopathologists at detecting clinically significant 2R or greater rejection at a one-sided alpha of 0.5% with 80% power. We conducted a sub-study within our validation phase, as I showed you earlier. And once again, the highlight of that particular slide was the Cohen's kappa of 0.47 in determining rejection that was grade 2R or greater, which is significant. And for the uninitiated, this would be the threshold for either increasing immunosuppression with pulse immunosteroids, steroids rather, or even further biopsy or plasmapheresis should this be determined as AMR type rejection. As discussed, our study endpoints were acute cellular rejection, immunosuppression exposure, infection, hospitalization, and death. The groups are well matched at baseline with respect to age, gender, etiology of cardiac dysfunction, ischemic time, CMV positivity, renal function, and CMR parameters. The key findings of the randomized phase of our study was that there was no significant difference in the number of patients affected by clinically significant rejection or the total number of clinically significant rejection events during the study period. 7 patients in the CMR group and 8 patients in the biopsy group experienced clinically significant rejection events. And in total, there were 22 significant rejection events in the CMR cohort and 11 significant events in the biopsy cohort. There was no significant difference in the cumulative freedom from 2R rejection events or time to first event between the 2 groups. I now draw your attention to these mosaic plots that illustrate the distribution and severity of acute cellular rejection in our randomized study. In the top panel, you will see the biopsy results of the biopsy group across time for each individual patient, from least to most severe. The purple squares represent 2R or greater rejection, the dark blue squares represent 1R rejection, and the light blue squares represent grade 0 or no rejection. This is replicated for the CMR group in the bottom panel. As you can appreciate, the number of patients who experienced clinically significant rejection was similar between the two groups. This is illustrated by the horizontal cutoff line on the Mosaic plots. For safety purposes, in this first-in-man study, clinicians were able to cross-check the results of any CMR with a biopsy if deemed clinically necessary. This occurred on 11 occasions. In 9 out of the 11 events, as depicted by the circles throughout the plot, the CMR rejection of severity matched the confirmatory biopsy rejection severity, further highlighting the reliability of CMR. On 2 occasions, as depicted by the triangles, CMR overcalled the severity of rejection, reinforcing the safety of CMR in not undercalling or missing significant rejection. Taking these confirmatory biopsies into account, a reduction of 95% in the total number of biopsies performed was observed in the CMR arm. Biopsy-guided weaning of immunosuppression over the course of the first year is well-validated and common practice. In this slide, we demonstrate that CMR likewise allowed safe weaning of immunosuppression over the first year. In addition, the total corticosteroid exposure and tacrolimus levels were not significantly different in either group.
Can I ask a quick clarifying question over there on the previous slide?
Sure.
So I see a lot more purple in the CMR group over here. Are those,
yes.
but there's no circles or triangles. Are they not biopsied?
Correct. So only when the clinician felt that there was a need to check or cross-check the CMR result was there a biopsy performed. But as you rightly pointed out, many of those times, or in far more of those times, the clinician felt that the clinical scenario fit with the CMR result, and management was initiated based on the CMR result.
And a follow-up, so those patients were treated as presumed CMR without knowing for
confirmatory
sure.
Biopsy?
Yeah, without, I mean, you wouldn't know if it's AMR or CMR, cell-mediated versus antibody-mediated, right?
Absolutely.
Just rejection.
Sorry, yeah, go ahead.
So then the treatment was just what? Just adjustment of steroids and tacrolimus?
Absolutely. So if it was felt that this was basically unresponsive to pulse immunosuppression therapy, then they were deemed required to do biopsies, etc., to confirm whether this was an AMR that was being missed. But our incidence of AMR was exceedingly low. In the randomized phase, we didn't have any AMR whatsoever. But this is one of the weaknesses I'll address at the end of the talk as well, in terms of how we can better screen these patients. But from our experience, if you do have AMR, usually the clinical picture is far more profound than cellular rejection, for example. And that's why in those scenarios where the clinician felt that this could be AMR, in 9 times the confirmatory biopsy was performed. And in none of those 9 times was it confirmed that it actually was AMR that was being missed.
Okay, makes sense. Thank you.
No problem. So just moving back to the infection rates, there was a greater number of infections at a patient and event level in the biopsy group, and this is driven by viral CMV and non-CMV infections predominantly. There were more hospitalizations at a patient level and event level in the biopsy groups, driven by the infection events that I described in the previous slide. From a CMR functional perspective, we compared functional parameters at baseline and at week 52. There was a statistically significant but not clinically significant reduction in right ventricular function in the biopsy group, with no significant change in other functional CMR parameters between the groups. Now, we can postulate as to whether this was all related to recurrent biopsies, but again, we didn't have the volume of data to make that assessment or correlation. Now, with regards to the reliability of the CMR methods employed to detect rejection, there was good correlation observed between the interventricular septum and global T1 and T2 mapping values, as depicted in panel A over here. Findings that formed the basis that in our cohort, we used interventricular septum regional analysis for all subsequent analyses and for detection of rejection. Importantly, there was also good correlation between T1 and T2 mapping values obtained between operators, as depicted in panel B, with the Bland-Ullmann plot depicted here in panel C. So in summary, we used Regions of interest in our T1 maps in the interventricular septum correlated really well with rejection. And the inter-observer variability was exceedingly low and was actually quite reproducible amongst observers. Now, touching upon the question that was raised earlier, so can CMR then be used to gauge adequacy of therapy in the setting of significant rejection? In our data cohort, the answer to that was yes. So this bullet plot depicts the response to pulse immunotherapy across the 2 trial phases for significant 2-hour or greater rejection, comparing time taken to resolve significant rejection events between the CMR-only group and the biopsy-only group. As you can appreciate visually, there was no significant difference in the time to resolution of rejection based on a CMR-guided treatment strategy or a traditional biopsy-guided treatment strategy, with time on the y-axis and the groups in the x-axis. So this is a scatter plot demonstrating the number of scans and biopsies per patient throughout the duration of the study. Based on the cost analysis for a single biopsy and rejection-focused CMR study, a $16,000 cost saving per patient per year was observed. Obviously, this is using Australian-based cost estimates. So in a program that does on average 40 transplants per year, this equates to a cost saving of about $500,000 per transplant center per year. In conclusion, I hope I've put forward to you that a CMR-based surveillance strategy for cardiac allograft rejection in the first year post-transplant is non-inferior for the diagnosis of clinically significant acute cellular rejection, safe as evidenced by the equivalent immunosuppression exposure and adverse events rates, provides prognostic functional information on the cardiac allograft, reduces the number of invasive biopsies by up to 95%, and is cost and time effective. There were limitations in our study. Firstly, it was a single center type study. We only used 1.5 T with regards to field strength, and there was a very low incidence in our antibody-mediated rejection, type rejection in our study cohort, and that was predominantly in the validation group. As I mentioned, we did. So where do we go from here? You need a multi-center study across field strengths and vendor software to establish universal diagnostic thresholds for the detection of various rejection grades, or come up with something like a Z-score to account for variabilities across vendors and field strengths. These studies should incorporate the use of promising biochemical and blood-based markers of rejection, such as donor cell-free DNA or gene expression profiling, in combination with CMR-based tissue characterization techniques for phenotyping of transplant rejection. There's new novel techniques such as diffusion CMR that could potentially add to the diagnostic accuracy of CMR-based detection of rejection. And ultimately, the goal will be the incorporation of a CMR-based invasive surveillance, non-invasive rather, surveillance strategy for the detection of allograft rejection in the first year post-transplant universally. Thank you very much.
Well, thank you, Chris, so much for that talk. That was wonderful, and thank you for walking us through your paper. I'd like to open it up to the group to see if there's any questions out there for Dr. Anthony about either his paper specifically or just kind of the topic in general.
Hey, my name is Nimish. I'm one of the Advanced Imaging Fellows. Just wanted to ask, we may have missed it in the beginning, but we were curious about your actual MRI protocol, like the imaging protocol that you use for this.
Sure. So we had a 1.5 Tesla Philips scanner. So for the tissue characterization sequences, we used the regular Molly sequence, a 533 type Molly. We had 8 inversion times, and that was fairly standard. If you're familiar with the Ike-Nagel sequences from the Brompton, we mirrored those sequences. And for our T2 mapping sequence, we used 8 echo times from a turbo spin echo type respiratory navigated sequence.
And sorry, what were your values for that?
The thresholds, you mean?
Yeah.
Sure. I'll just draw your attention to a slide at the end. So based on the validation cohort, these were the values that we came up with. So significant rejection in terms of T1 mapping value is anything above 1030. And for T2 mapping value, we got anything greater than 60 milliseconds. So this now corresponds very well to most centers that use 1.5 Tesla type scanners for detection of myocardial edema in general. For example, in a myocarditis protocol, etc. Again, our diagnostic accuracy for the grade 1 or intermediate type lower grade rejection was not as good, but we used the threshold of anything above 1,000 milliseconds for T1 and anything above 57 milliseconds for T2, and anything below those values was deemed no rejection.
And thanks. And did you also mention, do you also calculate ECV there too?
We didn't use ECV mapping because this was a non-contrast based study. So the whole goal was to minimize time and contrast exposure. And we found that when you combine T1 and T2 mapping in a multiparametric fashion, the additive impact of ECV was somewhat minimal in some of our initial workup studies. And to be honest, the data from the meta-analyses sort of confirmed that as well. If the most accurate way to pick rejection up intuitively is an edema-based sequence, we've got that with the T2 mapping. Combining T1 mapping sort of got our negative predictive value to close to 99%. So we didn't feel the need to expose these patients to contrast to generate an ECV map.
Thank you so much.
Hi, this is Otel. I have a question with the values, the thresholds that you use for T1 and T2. How do they compare to when you read other kind of studies like myocarditis studies? Are they in the same ballpark? Would you use the same cutoff values, or are these do you know these values?
Absolutely. So in our center, obviously we correlate this and validate this with phantoms initially, normal patients. And in our validation phase, we had non-transplant normals, we had transplant non-rejection patients, and then patients with rejection. And we found that the threshold values that we obtained were very similar to the actual, like I said, myocarditis cohort or even pericarditis cohort in terms of the threshold values that we used and on a 1.5T machine. And that was somewhat reassuring for us, in that generally when you're trying to detect edema or acute expansion of the extracellular matrix, that the values somewhat correlated across pathologies.
Thank you. That's very helpful.
I'm not sure if I missed this, but how early on was the first CMR screening? Because I feel like in the inpatient setting, it's more challenging, especially if the patient has a lot of epicardial wires or Swan-Ganz catheter. So I was just wondering about the first CMR.
Absolutely. So we waited for 4 weeks after transplant to actually begin enrollment and randomization. Reason being exactly that. We wanted to make sure the post-operative changes, edema, swelling, etc., settled down, so we didn't have any confounders to our edema sequences and values. So this was basically validated across 2 different randomized studies and 2 different patient cohorts. So in the RATAC study that I did initially, we found that, again, that 4-week mark seemed to be a very safe point to begin CMR scans on these patients without any confounders, as you mentioned.
Thank you. So in the beginning, like for the first 4 weeks, did they use like biopsies and then move to the CMR?
Absolutely, correct. So the first month, all patients had their routine biopsy-based surveillance regimens, and at the first month, they then transitioned to either the biopsy or the CMR.
Thank you. That's helpful.
We have a question from one of our friends, Dr. Farr is joining us from UT Southwestern in Dallas. So Dr. Farr.
Hi, thanks for Yale, as always, being so gracious with the invitation. I'm the section chief down at UT and a transplant cardiologist. So this is obviously your niche and space and expertise. One of the things that's so hard, this is a terrific study, and you presented this so nicely. You know, obviously clinically where we get into trouble is we obviously want to stop biopsying after a certain point, which is of course the whole point of your study. And then we also want to use some simple techniques like cell-free DNA, but then as soon as you have some vasculopathy or some donor-specific antibodies, then those waters get muddied. But one of the things that patients really want to know about is of course long-term survival. So I'm wondering whether you are working on or and maybe Yale, you're maybe embarking in this area, is take your survivors, the people who are alive and doing okay at 20 years, 25 years, 18, 17, and going back and trying to look at degree of fibrosis and those types of things to try to predict longevity. And then I guess the other thing is, the one thing that we know about these patients is when they do die, they die of PEA and bradycardia and not VT. which is always a little bit confusing, but it is the case. And I just wondered whether you have any correlate for that or any thoughts about that. And one last thing, there's a recent Circ paper about just LGE, right, in patients with sarcoid may be more predictive of who needs a defibrillator than EF. So a lot of ideas there. So any comments?
No, thank you. Those are all great ideas. I think to start off initially about survival, mortality, I think the question there predominantly circles around allograft function and how do we better characterize or quantify that. I think, as you've already alluded to, CMR is very exciting in terms of its tissue characterization properties. That's what I did in the RADTAG study, where we used T1 mapping longitudinally in a transplant cohort. We had one cohort who actually used PSI, so everolimus, included into their immunosuppression regimen, compared with the usual CNI tacrolimus-based immunosuppression regimen. And we found that the everolimus group actually had reduction in their T1 mapping values, with better circumferential strain by CMR as well, which was a surrogate that we used to sort of quantify subclinical allograft dysfunction. Because as you're aware, if we use echo or even CMR, which is meant to be the best to assess ejection fraction, that's more of a global volumetric type assessment of LV function. But we know that there's different paradigms as to LV function in general or graft function in general. So CMR really is a great opportunity, as you alluded to be able to assess multifaceted areas of graft function, not just eyeballing or volumetric assessments of overall ejection fraction or right-sided heart function, etc. And it definitely is interesting to see that, having demonstrated that there's certain immunosuppression regimens that may reduce the degree of scar and fibrosis in the graft to begin with, when we look at them longitudinally, that there might be some benefit to actually working out what the scar burden is at the offset, and then trying to see if there are different things that we can do, be that immunosuppression or better control of other risk factors that may promote graft dysfunction or fibrosis or scar, for example, being aggressive with CAV, or better control, not that you don't, of blood pressure, etc. Things that reduce subclinical graft dysfunction or promote scar formation in these patients. And your comment about sarcoid and Lake Elim enhancement and increased incidence of sudden cardiac death, we're seeing that the presence of LGE across a myriad of pathologies actually is prognostic and predictive of not just SCD, but death in general. The other work I'll draw you to is in the HCM cohort. Cleveland Clinic and Melinda Desai essentially published this very good longitudinal follow-up data that looked at trying to come up with a parametric way of quantifying scar burden in patients with HOCM who didn't quite meet the criteria for an ICD based on the traditional criteria. And he found that if you had 15% worth of scar compared to your LV mass using an LG threshold of more than 6 standard deviations from normal signal intensity, that was actually prognostic in terms of their risk of increased risk of sudden cardiac death. And that is now taken into consideration with regards to earlier implantation of ICD, for example. So I think there's definitely a role for this, and there's definitely an opportunity to do this. But a lot of this is probably will need to be done prospectively in terms of getting what the baseline scar burden is, tracking that prospectively, and then working on outcomes.
Thank you. That was terrific.
Just one more question back to the rejection assessment. First of all, this is a fascinating trial. This is probably one of the few trials that actually doesn't compare any non-invasive modality to biopsy per se. You're not holding biopsy as a gold standard. You're doing an intervention on the patient and then looking at the same CMR for results. So this is very different, as we all know, the pitfalls of biopsy. So this is great. So the question I have is, were you treating with a T1 of 1,000 cutoff over here, where it says high probability of 1 R, or were you waiting for 2 R here? I mean,
sure.
When did you decide to treat on the CMR?
Thank you. So when we got what we call a highly probable or probable 1R, what we would more likely often do is actually just hold the immunosuppression at the current levels. So we'd obviously you gauge the clinical state of the patient, how they're feeling, the other parameters. If we got anything below that 1030 T1 mapping value or 16 a T2 mapping value, the inclination would be to just hold the immunosuppression at the current level as opposed to reducing it. Because obviously as clinicians in the transplant field, we're always battling the want or the desire to wean immunosuppression as much as possible, i.e. balancing the infection risk with the risk of rejection. So we would just use that as an indicator to sit tight and then wait till the next CMR to reassess, if that makes sense. As opposed to if we got a value below 1,000 or below 57, we'd then be more confident and would actually wean or reduce the immunosuppression at that point.
Sounds good. Thank you.
Well, I want to thank everybody for participating. This was a wonderful discussion, and thanks, Chris, again for taking the time to join us early morning in Melbourne, Australia. And it'd be great to hear from you again. And again, everybody who joined, thank you again so much for joining and participating. And we'll have our final talk of the calendar year next week, which will be on the role of artificial intelligence in identifying patients who are candidates for advanced heart failure therapies. So that should be interesting as well. Everybody have a great day. Bye-bye.
Thank you very much. All the best.
Thank you.